these are my conflict of interests. I'm co-founder, stockholder of a company that was a spin-off company, University of Maryland, on treatment alternative to the gluten-free diet, but we're not going to discuss this topic today. Rather, the objective of the lectures today is to understand this interplay between gluten, that is the culprit of these gluten-related disorders and genes, how this translates in a clinical outcome that we thought that was just celiac disease and nothing else. And also, we realized that the recipe for this condition is much more complex than we perceived before. And indeed, besides the host genes and the environment, there are many other components that seems to be important for the clinical outcome that we're going to review briefly during this little chat. Why we realized that the celiac disease was not the only culprit of gluten-related disorders? Well, it was an epiphenomenon that we learned from the market of the gluten-free diets. Here, there are 3 diets that have been compared, 3 popular diets, in a span period of roughly 12 years. You have in orange the low-carb diet, and then you have the fat-free diet in red, and the blue is the gluten-free diet. And you can appreciate as, looking at this graph, that the gluten-free diet was not popular at all until the recent past. So that roughly, 6-7 years ago, the gluten-free diet became the most popular diet in the United States and never looked back. And by the way, now it's by far the most popular diet ever been embraced in the United States. So the projected numbers are astonishing. There are many people there on a gluten-free diet, way beyond what is the projected number of people that are affected with celiac disease in the United States, roughly 350,000. Right now, by the end of the year, almost 100 million people, 1 out of 3 individuals that lives in the United States will consume a gluten-free product. So that means that there are many more people that eat gluten-free that are projected to be on a gluten-free diet because of medical necessity. So that spanned to, the news to consider this yet another fad diet, like, other diets that were popular in the past. So no question, there is a fad factor for the gluten-free diet, particularly because there are, icons, individuals, role models like actors and sportsmen and politicians that embrace this gluten-free diet, and therefore, they are kind of followed by individuals because they feel that if they're good for them, it should be good for everybody else. The reality, if you dissect who are these, 100 million people that go gluten-free, they can be divided in 2 major groups. The ones that they occasionally consume gluten-free products. So in other words, they go gluten-free, no for medical necessity. And these are the bulk, the vast majority of people that nowadays embrace the gluten-free diet. Roughly half of them, 50 million, they go gluten-free because they believe the gluten is good for you, that the gluten-free diet is good for you because gluten can cause some problems. So it's healthier to eat gluten-free. Another roughly 35 million people, they go gluten-free because they believe that they can lose weight that way. That is not really scientifically correct. Actually, if you abuse with gluten-free counter products like gluten-free pasta and pizza and beer, you will end up to gain weight and not losing weight because in general they tend to be hypercaloric. So this is the bulk of the people that are driving this market of gluten-free products. However, the other group, the one that we're going to discuss together today, is the one that have to embrace the gluten-free diet because of medical necessity. And now we know that these are divided in 3 subgroups. People that are affected by wheat allergy, that is roughly 0.4% of the general population. People that have a problem with celiac disease, so the autoimmune component of the reaction to gluten, it's roughly 1% worthwhile. And then this new entity, gluten sensitivity or non-celiac gluten sensitivity, that we discuss a little bit more in details since it's the last kids on the block, and therefore there is a lot of misconceptions about this entity. And the prevalence, we don't know for sure. There are some estimates. I put here number 6%. That is the estimate from our center at MGH for children, but we're going to discuss a little bit more about what is the state of the art in terms of the epidemiology of this condition. So let's start with the good, the wheat allergy. It's like any other food allergy, mostly Ig mediated. and depends on the underlying immune process that is in the heart of the pathogenesis of this condition. So you have IgE productions, and they have to release the histamine, and the symptoms that are related to that. They are typically the ones that you experience with any other food allergy. It's much more common in the first year of life, and then decrease toward adulthood. As a matter of fact, wheat is among the 10 most important allergens for food allergy. The prevalence in the first 3 years of life between 3 and 8%, and is together with milk, egg, corn, and peanuts among the most common food allergens that, as we discussed before. There is, however, an overestimation of what is the impact of wheat allergy in childhood, because there is a discrepancy between what is reported by the parents. They feel that gluten-containing grains like wheat are causing the allergic reaction in the kids, and the objective finding when we do tests for food allergies. The typical clinical manifestation, again, are not different from any other food allergy that include abdominal pain, nausea, vomiting, diarrhea, skin rash, runny nose, and conjunctivitis. Of course, can go all the way to anaphylaxis in the very severe cases. This condition, eosinophilic esophagitis, that is really increasing worldwide with symptoms that overlap to gastroesophageal reflux. It's really driven by a feeding aversion and dysphagia and food impaction that is the objective report of patients, but it's also now linked to many multiple food allergies. And the diagnosis now is pretty much on the premises of an endoscopy with biopsy that shows this infiltration of eosinophils, i.e. the immune cells that drives this condition that we call eosinophilic esophagitis. So the treatment of this is the use of amino acid-based formula, and most importantly, elimination diets, and sometimes in more severe cases, there is the need to use topical steroids. And of course, there are complications that can arise from not well-treated EE, such as esophageal strictures, and it can go all the way to perforation. Now, wheat seems to be one of the food allergens that eventually can drive this eosinophilic esophagitis. Another interesting aspect of wheat allergy is what we call the baker's asthma. It's one of the most common asthma associated to a specific occupation. It's caused by inhalation of syrup proteins, rye wheat most common than the others, and may also be driven by potential contaminants that have been in the aerosol during milling or baking process. In general, kids suffer that, as not as a worker, but if they spend a fair amount of time in this kind of facilities. The symptoms are typical with asthma, with cough, wheezing, chronic congestion, rhinitis, and conjunctivitis. This is probably the most rare but most intriguing reaction to wheat in terms of allergy, what we call wheat-dependent exercise-induced anaphylaxis. It is very difficult to make the diagnosis, so you have to have a high index of suspicion for, point in the right directions. The ingestion of wheat is a precondition to develop this exercise-induced anaphylaxis. The clinical picture does not really manifest unless there is in general, severe, sustained exercise. The intensity of the exercise can be, though, variable from one individual to another. The vast majority, again, needs to engage in extreme exercise, like running a marathon. But there are some people that are extremely sensitive. So just playing ping pong or walk uphill can induce the exercise anaphylaxis. Exercise within 2 hours, the ingestion of gluten carries the higher risk in leading to this chain of events with immune reaction that eventually leads to this final destination, the anaphylaxis. Multiple factors play a role in causing this severe reaction to wheat. including the dose of protein ingested, the intensity of exercise, as I was telling you before, the timing between ingestion of wheat and exercise, and individual factors that like, fatigue, menstrual cycle, and so on and so forth. Some drugs like aspirin can aggravate, the outcome. And therefore, the people that they have suspected or proved wheat-dependent exercise induced anaphylaxis should be very, very careful in engaging in any strenuous exercise within 4 or 5 hours postprandially. Now, this is pretty much the overall look of the good, wheat allergy. Now, what about the gluten sensitivity? I was telling you this is the new kids on the block, and probably the best way to really start the discussion is the description of a case. This is AJ, a 17-year-old female with a 6-month history of recurrent abdominal pain, mainly epigastric heartburn. And of course, this led to suspecting a gastroesophageal reflux disease, was placed ex-adjuvantibus on proton pump inhibitors, but there was no resolution of the symptoms. What really created a major concern in her pediatrician was that 1 month after the onset of these GERD-like symptoms, she developed headaches, dizziness, numbness of fingers, paresthesia, a gradual reduction of legs muscle strength that brought her to be confined in a wheelchair. Of course, the pediatrician suspected some neurological causes, sent to a specialist, and she underwent a series of tests like MRI and evoked potentials to rule out early stage multiple sclerosis, and both results negative. Other diagnoses were engaged, like Lyme disease, Epstein-Barr virus infections, pernicious anemia, lupus. All of them were ruled out. Now we are 2 months into the history, and because she had persistent gastroesophageal reflux symptoms, she underwent to an endoscopy that was reported normal with the small, finding of some increase intraepithelial lymphocytes. These immune cells, they are present on the epithelial, layer that can be, part of an unspecific finding. She also was screened for celiac disease and test negative. So everything was pretty much ruled out. There was no clear indication what was wrong with her. Among the other tests she did, she also was tested for the anti-gliadin antibodies. That, as you see in a moment, that is a test that was abandoned almost 30 years ago because it's not sensitive and specific enough for the diagnosis of celiac disease. So we don't rely on this test anymore to diagnose people with celiac disease. Nevertheless, she was tested for these antibodies. She tested positive for one of them, specifically the anti-gliadin IgG. And based on this, and based on the fact that nothing else was positive, and therefore there was no diagnosis, her family decided to put her on a gluten-free diet. And this was against the advice of the pediatrician. Within 3 weeks, her GI symptoms resolved. Within a couple months, her neurological symptoms also improved. 6 months after the implementation of gluten-free diet, she was able to leave the wheelchair and start to walk again. And 12 months later, she regained completely her walking functions. So what is this? Again, nowadays, we call this gluten sensitivity or non-celiac gluten sensitivity. What is the definition of this condition? Since we don't have tests yet, this is a diagnosis by exclusion, as happened in this clinical case. So we define gluten sensitivity based on a series of consensus conference that, starting from 2010, those cases that react to the ingestion of gluten-containing grains with symptoms in which both allergic, i.e. the ones that we just saw, the wheat allergy, and autoimmune mechanism, i.e. celiac disease that we see in a moment, have been ruled out. So it's by exclusion criteria. So it has to be a condition that is triggered by the ingestion of these grains, has to have negative results for immune test for wheat allergy, negative results for the celiac disease screening. The intestinal biopsy has to be normal, as in the clinical case that I just described to you. And also, as described in the case, there is a possible presence of biomarkers of gluten immune reaction like anti-gliadin antibodies positive. And there must be the presence of clinical symptoms that, however, are not helpful for a differential diagnosis because they completely overlap the symptoms of celiac disease and with allergy, and the symptoms needs to resolve when there is an implementation of gluten-free diet and relapse when gluten is reintroduced in the diet. And to avoid a placebo effect, ideally, this challenge should be done in double blind. So what is the magnitude of the problem? As I was telling you, we have an estimate, and we cannot put out there more than an estimate, because if we don't have biomarkers, we can't do epidemiological study to have a precise evaluation of what is the prevalence of the disease. So roughly, based on our data, we have an estimate of roughly 6%, but in the literature there is everything from 0.5% to 95% of the general population is affected by gluten sensitivity. Of course, these two extremes, they are very hard to really sign off. I think that, again, until we don't have validated biomarkers, it will be very, very difficult to make a statement how frequent this condition. But the general sense, based on, general surveys, is that it's more frequent of celiac disease, so more than 1%. What are the symptoms? Here to see a descending, frequency of the symptoms. On the top is abdominal pain, but these people, they have also extraintestinal symptoms like eczema, skin rash, headaches, foggy mind. 1/3 of them, they report this very interesting factor. Chronic fatigue, diarrhea, depression, anemia, and so on. Bottom line, as I was mentioned before, totally indistinguishable on the clinical ground from celiac disease that pretty much have similar symptoms in patients that are affected by this condition. So how do we make the diagnosis? And what is the take-home message about gluten sensitivity? It's not rare. Cannot be distinguished from celiac disease purely on a clinical case basis. As I told you, they overlap. Can present with vague, non-specific symptoms. A gluten-free diet can be considered, and I believe that this is the most important point that I want to communicate, only when other form of gluten reaction and other causes of the symptoms have been ruled out. Because if we start a gluten-free diet before ruling out possibility of celiac disease or with allergy, the tools that will allow us to place this individual in this spectrum of gluten-related disorders are not there anymore. So we would not know if this individual belongs to celiac disease group, to wheat allergy group, or the gluten sensitivity group. Last bullet list is listen to your patients. This is a reminder for myself, because at the beginning I was very, very skeptical that there was any other conditions other than celiac disease can be triggered by gluten, but the clinical experience taught me otherwise. Now, particularly hot topics of gluten sensitivity are the controversial question of the role of gluten in some specific condition like autistic spectrum disorder and schizophrenia. And, there are some, division in the individuals. They are experts in the fields. They are divided in believers and non-believers. The believers, they see a role of the gluten-free and casein-free diet in the treatment of these conditions. The non-believers, sustain that, the gluten-free diet has no role whatsoever. But this is a very dynamic work in progress. I don't think that we have any final say which one is right, which one is wrong. In general, as typically happens in this situation, the truth is somewhere in the middle. So while it's inconceivable that everybody with this condition can be treated successfully by eliminating gluten from their diet, it's also very unlikely that gluten has nothing to do with this condition, because besides the personal reports from families, there are some objective findings now that really are piling up in the literature that suggests that at least a subgroup of these individuals may be reaching these final destinations, because these are final destinations through the route of gluten sensitivity. So when we will be able to find and validate biomarker for gluten sensitivity, chance exists that we will be able to stratify the population to find those individuals within this very, severe conditions. They are absolutely an orphan of any solution right now. Those then may eventually benefit by embracing the gluten-free diet. And let's finish off with the ugly, the celiac disease. I decided to give the ugly role to celiac disease because this is the autoimmune response to gluten. It will not go away, so you will deal with this for the rest of your life. But among all the autoimmune diseases, this is really special, as you'll see in a moment, because it's the only one for which we have a treatment. But also, not only clinically is one of a kind, but also as a model for autoimmunity is teaching us so much. And it's our hope at the center that sometimes, by studying the intimate mechanism that leads to celiac disease, we may eventually unleash the knowledge to understand better other autoimmune diseases and eventually find solution for these other autoimmune diseases like diabetes, rheumatoid arthritis, and so on and so forth, for which, unfortunately, we don't have any solution right now. So where the story starts, when we start to really be aware about celiac disease, the start starts, as far as 2,000 years ago when Greek physicians for the first time described this condition. But the real story, it's set in 1861 when a pediatric gastroenterologist at Great Ormond Street in London for the first time gave the description of celiac disease as we know it now. And this was Dr. Samuel Gee that gave this historical talk in 1861. However, we knew there was a pediatric condition at that time. That's the way that was described, even if at that time Dr. Samuel Gee already made the mention that it can be affected at any age, but we learned this much later, but was mainly a pediatric condition, was exclusively a gastrointestinal condition. So in other words, the symptoms were gastrointestinal and had a mortality rate that was pretty high, 35%. And we had no idea what would make these people sick, but there was the suspicion something in the diet was driving this condition. He didn't know what. Who really pinpointed the right direction was this Dutch pediatrician that you see here, that is Dr. Dickey, that during World War II made a very interesting observation. During that time, wheat was scarce and not available. Flour was made potato starch and not with wheat, and the mortality went to zero. To return to, to pre-war era mortality, 35% when the war was over and wheat was again available. Therefore, he hypothesized that was the wheat that was the driving force for celiac disease. And to prove that, he did a clinical trial with 6 kids, that's all. And with 6 sick with celiac disease, he placed them on a gluten-free diet. The symptoms went away. He reintroduced gluten in the diet, showed that the symptoms came back. And that remains the pillar, the cornerstone of what is our understanding about the genesis of celiac disease and the way that we treat it with a gluten-free diet. Fast forward to 2014. What do we know now? We know that it's not a food allergy, as was stated before. We know it's not a food intolerance or sensitivity. It's truly an autoimmune disease, as I was telling you before, but one of a kind. Has the same ingredients of the recipe. There is a genetic component of the disease. There is an environmental factor that triggered the disease because of this genetic component that makes the immune system to react in an inappropriate way. The immune system is there to defend us, and therefore, when exposed to non-self antigen, is built to get rid of them. But with people without immunity, rather to get rid of the invader, start to attack its own body. In celiac disease, the target being the intestine. But why is peculiar? First of all, the genetic component. It's quite peculiar because it is an autoimmune disease in which there are specific genes, particularly this class 2 HLA, DQ2, DQ8, with a superbly high penetrance. We don't have any other disease that has close to 98% of penetrance in which either or both these genes are to be there. So much so that clinically now we define almost impossible to develop celiac disease if these genes are not there. The second peculiarity, we know the autoantigen, this enzyme, intracellular enzyme that is called tissue transglutaminase. As a matter of fact, the antibodies against this enzyme is one of the best and most robust tools for screening of any disease of humankind with a superbly high sensitivity and specificity. But what really set this autoimmune condition aside from all the others is the only one for which we know the trigger, that is gluten, because of Dickey's observation. So it's the only autoimmune disease for which we have a treatment, not a cure, but a treatment, because an individual, a kid with celiac disease that is placed on a gluten-free diet, provided they are not complications that cannot be fixed anymore, will have the symptoms to go away. The autoantibodies, they are the biomarkers of the autoimmune process that will go away. And the autoimmune insult, i.e. the enteropathy, that will go away. Bottom line, these kids should be and will be undistinguishable from anybody else that is healthy out there. So, nevertheless to say that when celiac disease was moved from the food intolerance / allergies to the box of autoimmune diseases, created tremendous turmoil in the scientific community, since the premises of autoimmune diseases was they are not treatable. It's a one-way and you cannot come back. Celiac disease proves otherwise. It's proving that provided you can stop this ongoing crosstalk interaction between genes and the environmental trigger, by, in this case, eliminating the environmental trigger with the diet, you can stop the autoimmune process. And that's the reason why, as I was mentioned before, celiac disease became not only quite an interesting, clinical, condition, but also, scientifically speaking, is really providing us tremendous insights of what the autoimmune process are all about. So let's dissect a little bit about this component and see how important clinically is to know these pieces of the recipe. As I told you, this is an autoimmune disease, so it's multifactorial. Many genes are involved. We don't know how many. So far, there are roughly 45 genes that have been linked to celiac disease, but the most important, the ones that give the almost 60% of the genetic weight for celiac disease, are these HLA genes, DQ2, DQ8. They are absolutely necessary. So they are an integral part of the genetic puzzle. So you got to have that, but not sufficient. You need to have other pieces of the puzzle in order to develop celiac disease. And the reason why we know this is because 1/3 of the general population, roughly 35% of the individuals, they will have these genes, but will never develop celiac disease because probably, actually, most likely, they missed the other piece of the puzzle. On the other hand, if you have all the other pieces of the puzzle, but you miss this one, you still cannot complete the genetic, puzzle of celiac disease. So even if you have all the other genes, missing this will not allow you to lead to celiac disease. So bottom line, the presence of the HLA is not discriminatory, will not tell you if you have celiac disease or not. But their absence, it's pretty much a done deal in excluding celiac disease. So the checking of the HLA, as we see in a moment, has a tremendously valuable negative predictive value. What about the second component, the environmental component? Well, we learn a great deal about this because, first of all, we realize that we as a species did not evolve to eat gluten. Matter of fact, for the 2.5 million years of evolution of humankind, our ancestors have been gluten-free for 99.9% of the time that we spent on Earth. Gluten came into the picture only in the last second in evolution, 10,000 years ago, when our ancestors dramatically changed their lifestyle from nomadic, i.e. moving around with the migration animals and the seasonal crops, to settlers, when they domesticate animals and crops. And by doing that, they start to play with grains and create the ordi, this tribe from which wheat, rye, and barley belong to, and these are the grains that contain gluten. So we, again, did not evolve to deal with these grains. While we, for many, many years, hundreds of thousands of years, we deal with rice, milled rice, oats, and finger millet, and so on and so forth. What is the outcome when these two ingredients come together? Well, clinically speaking, the best description has been this concept of the celiac iceberg. To belong to the family of celiacs, you have to have minimal requirements. As I told you, definitely the genetic susceptibility. So you have to have those genes, including the HLA, DQ2, DQ8, to be genetically compatible with celiac disease. To belong to this iceberg also, you have to have the autoimmune process ongoing, i.e. positive serology, i.e. the autoantibodies are telling us that something is going wrong, that the immune system is pointing his weapon in the wrong direction, creating the condition of autoimmunity. If on top of that, you have the damage of the intestine, so the autoimmune insult, that leads with symptoms, then you are visible. You're on the top of this iceberg because now you have symptoms, and therefore you will probably be brought to a physician to find out what's wrong with you. So that is the concept of the tip of the iceberg, and implicit this concept, the fact that only a minority of celiac disease people will present with symptoms that are clearly linked to celiac disease. or symptoms that are severe enough to go to a doctor. The vast majority of the problem in celiac disease is underneath the line of water, with silent celiac disease, in which, of course, you have the genetic susceptibility, you have the autoimmune process ongoing. There is the autoimmune insult, but the symptoms are not there quite yet. Don't be surprised about this. You know, the target organ is a pretty long tube, so if some of this, you know, intestinal wall is damaged, it doesn't do anything peculiar in terms of absorption and digestion of food stuff, the rest of the intestine can subsidize it. And therefore you become, you know, you will be clinically silent. Over time, eventually, you will develop symptoms. And then there is the latent form of celiac disease, in which you have the genetics, you have the autoimmune process, but the autoimmune insult to the mucosa is not quite there yet, and the symptoms are not yet there. If we take a snapshot of 100 people with celiac disease right now, roughly 50 will be here, 40 will be here, and only 10 on the top. And until the very recent past, until a breakthrough study was published by our center, the concept was that everybody has to go through this journey. So you're born with the genes, you eat gluten when baby food is introduced, because no matter who you are, where you live, gluten comes into the picture when solid food is introduced in the diet. And that's when the process starts. That's when you got into this iceberg. And you start latent, and then eventually you go up to silent, and then eventually you become clinically apparent and will be diagnosed. That was the concept until the recent past. So where are the clinical manifestations? The classical manifestation, the ones that we thought until the recent past, the only manifestation of celiac disease is the one that you see depicted in these slides. Typical malnutrition kids, these are a picture in the late 40s from London. They are not distinguishable from kids that nowadays they have this kind of clinical presentation because they have kwashiorkor, for example. So chronic diarrhea, big belly, lack of appetite, failure to thrive, a stomachache, vomiting, constipation, irritability, and rarely you go to the celiac crisis that was the reason why these kids, you know, eventually would die. Now, why they look like this? You know, today, kids, they look like this because they don't have food. So they cannot eat enough calories, and that's the reason the clinical presentation. These kids can eat everything that they want. They cannot make use of it, just go through. And that's the reason why they develop these symptoms. Once again, the misconception was that this was the only way that the disease presents itself. And based on this misconception, we always believed that celiac disease was extremely rare in the United States because we never seen anything like this. However, over time, when our diagnostic tools were refined and large epidemiological studies were made, we became to appreciate that the picture is much more complex than just the classical presentation. This is the real celiac disease. So there is no organ or tissue in our body that is spared by the autoimmune inflammatory process that characterizes celiac disease. True, the battlefield is the gut. That's where the process starts. But these immune cells may eventually leave the gut and go somewhere else, like in the skin, and create inflammation there that translates in dermatitis perdiformis. Can go to the bones, and not only because you don't absorb calcium, vitamin D, but also because there is an autoimmune attack in the bones, you can develop osteopenia, osteoporosis, and so on and so forth. Of these symptoms here, I want to point to that I believe are extremely important. The first one is iron deficiency anemia. Today is the most frequent way that celiac disease presents itself, both in pediatrics and adults. Just anemia and with that chronic fatigue. And this is anemia that cannot be corrected by other iron supplementation. The second one is short stature, that in pediatrics, it's something that is extremely important. If a kid with celiac disease starts puberty without being diagnosed, chance exists that will never be able to catch up and will remain short for the rest of his or her life, mainly because we missed the diagnosis. So it's extremely important to consider the differential when we're talking about short stature, the very, very top celiac disease. So if we engage in the possibility that these kids, they have growth hormone deficiency, 1 in 10,000, of congenital hypothyroidism, 1 in 3,000, please consider celiac disease 10%. 10% of the cases of short stature. So I think that, again, it's worthwhile to invest the $70, $80 of screening tests for the diagnosis of celiac disease when you deal with the kids with short stature. So I will say, let's be proactive, because a diagnosis made on time will allow catch-up growth and prevent something that cannot be fixable anymore if we don't make this on time. There are also associated conditions that it's quite interesting that are much higher than a general population, like genetic disorders and syndromes, other autoimmune conditions, and of course, because this is a genetically driven condition, relatives of biopsy-proven celiac disease, they have a higher risk to develop celiac disease, like 10 times more. And that's pretty much what we have now. This is a combination of several studies in the literature, and the line shows you the average. So roughly, as I was telling you, 10% of first-degree relatives, 7-8% of type 1 diabetes. This Hashimoto thyroiditis, autoimmune thyroiditis, is quite an interesting phenomenon, because until 20 years ago was down here, roughly 4%, that was only adults. Now we see this much more frequent, and we see in pediatric population as well. An association that we see now, quite often, and we still don't understand the genesis, is with Down syndrome. Roughly 7-8% of kids with Down syndrome, they have celiac disease. And we walk back and forth on chromosome 21 to try to find something there, but we didn't find anything. So Down syndrome, again, it's quite frequent, but other genetic disorders like Turner, Williams syndrome, IgA deficiency, these are, all conditions in which celiac disease is more frequent than in general populations, 1%. Because the screen test that you see in a moment is IgA-based, the IgA deficiency can really complicate the serological screening, because we don't have the proper tool to make the diagnosis, so we have to use alternatives. So there is a comorbidity with many autoimmune diseases. I told you already, type 1 diabetes would range between 3.5 and 10%. The Hashimoto, that now is much higher than this, as I told you. Arthritis, 7.5%. Autoimmune liver disease is pretty high. Sjogren's syndrome, that it's more an adult condition. And idiopathic dilated cardiomyopathy, IgA nephropathy are all extremely frequent among people with celiac disease. So bottom line, all this to say that it was a no-brainer, well, at least justifiable, why celiac disease was overlooked for so long in the United States, because this truly is a clinical chameleon. Compared to other autoimmune diseases, there is no clear direction that the clinic can give you to make a suspicious celiac disease, because it's a systemic disease. You can have symptoms that have nothing to do with the intestine, and therefore you can be really challenged, clinically speaking, to make the proper diagnosis, unless you are intimately and deeply aware of what celiac disease can do in terms of clinical outcome. What about the diagnosis? So this is an embarrassing slide that I have to present anyhow, because it's a no-brainer that you, for any kind of condition, you need to confirm the diagnosis before treating, right here. However, unfortunately, this is not the case in celiac disease. Many, many times, particularly now that we're in a global village of communication, there are people that place their kids on a gluten-free diet to give it a try, because the symptoms are compelling, and because maybe that they've been frustrated by many years of misdiagnosis, and now they find the answer on internet, they will give it a try. But once again, as I mentioned before, you go gluten-free, you subtracted the tools to make the proper diagnosis. Now you don't know, assuming that this kid will respond positively to the elimination of gluten from the diet in terms of resolution symptoms, you don't know where this kid will be in this spectrum of gluten-related disorders. We are here to improve quality of life for these kids. So failing to treat potential celiacs, of course, they have a long-term adverse events, short stature, for example, one that I was mentioned before, but also place a kid for the rest of his or her life on a gluten-free diet when he or she does not belong there, has a negative impact on quality of life. So we need to be aware about that. What are the serology tests that we have now? This is a review that we recently published in New England Journal of Medicine. The bottom line, as I was telling you, the antibodies against this tissue transglutaminase, it's an extremely robust test for screening in terms of sensitivity and specificity. It's definitely now the recommended first level screening test. With the caveat, again, that is IgA-based, so IgA deficient kids, they may test falsely negative. The IgG-based anti-TTG antibodies are extremely variable in sensitivity and specificity, and therefore they're not that useful as an alternative test. The anti-endemism antibodies, it's also been used for many years, but it's operator independent, so it's very difficult, it's time-consuming, it's very expensive, so it's not used now as a first line of diagnostic, but it's rather used when we have uncertain diagnosis and specifically in conditions in which the anti-TTG antibodies can test falsely positive. The new generation anti-gliadin antibodies, so in other words, the deamidated gliadin antibodies, what we call DGP, they are very useful for the cases of IgA deficiency because the IgG subgroup of the DGP, they are performing much better than the IgG anti-TTG antibodies. So nowadays, we tend to use the IgG deamidated anti-gliadin antibodies in those cases of suspected celiac disease in which we have IgA deficiency. And finally, the HLA testing, again, has a strong sensitivity, but because, 1/3 of the general population, they also have these genes, is not good in terms of specificity. So in other words, we test for HLA. So far, we've been testing the HLA to rule out and not rule in celiac disease. Where are the value? Again, the negative predictive value is extremely strong. So you can reassure, somebody that would never develop celiac disease unless we're talking about excruciatingly rare cases if they test negative for the HLA, DQ2, DQ8. Where are the indication? Until 3 weeks ago, these were the indication. We do HLA testing for asymptomatic relatives. So in other words, the rule now is that if you have a family member has been diagnosed with celiac disease, the rest of the household needs to be screened. And the typical question that we receive all the time is, if these other family members, they test negative, how often they need to be screened for celiac disease? And the best way to answer that is to perform both the serology test and the HLA tests. If they test negative for the serology test and negative for the HLA test, you can reassure the family that this kid should not be screened anymore unless excruciatingly rare circumstances I was telling you before. If, on the other hand, they test negative for serology and positive for the HLA, we're not saying that this is for sure that will develop celiac disease. It's just that genetic compatible. So in other words, has one of the pieces of the genetic puzzle to develop celiac disease. So this kid can be kept under a watchful eye to see if indeed he or she may eventually develop symptoms can be compatible with celiac disease. Other conditions for which we use the HLA is the condition which there is high comorbidity with celiac disease that you see here, Down syndrome, Turner syndrome, Williams syndrome, type 1 diabetes, and then the diagnostic dilemmas, i.e., for example, the cases that I was telling you before. Kids have been already placed on a gluten-free diet without having a diagnosis secured. The only thing that you can offer to the family is to challenge, re-expose to gluten, start all over again, and then look for the biomarkers with celiac disease or with allergy to figure out in which part of the spectrum this kid is. A lot of families are really reluctant, particularly if there's been a dramatic improvement of the symptoms, to place these kids on a gluten challenge. So the first thing to do is eventually to do the HLA test. If the HLA test is positive, the challenge, it becomes necessary because all the bets are still on the table. If the HLA is negative, at that point you can reassure with great level of confidence celiac disease is not responsible for the symptoms of the kids, so you can assume that this kid most likely has non-celiac gluten sensitivity. But one more, indication came with this paper that we just published on October the 2nd, in which we look at a large cohort of infants at risk of celiac disease from birth, more than 750 kids. They've been followed for 10 years. And we look at many, many aspects of what is the interplay between gluten and a subject at risk, among the others, this HLA status. And we learned something that was quite remarkable, that if these kids are at risk, they have 2 copies of the HLA DQ2. So in other words, they got 1 copy from one parent, the other copy from the other parents. And therefore, they're homozygous for HLA DQ2. Their risk for celiac disease increase exponentially high, close to 40%. So General population, 1%. If you're first-degree relatives, 10%. But if you have 2 copies of the HLA, your first relatives can go as high as 40%. So in the future, probably another indication for the HLA typing is in subject at risk to see where are they in terms of the genetic weight eventually to develop celiac disease. Now, what about the epidemiology? The increase of understanding of the epidemiology went vis-a-vis with the development of new tools for the diagnosis of celiac disease. Again, in the mid-70s, the anti-gluten antibodies were, developed. As I told you, they're not used anymore because they're not specific. And then the anti-endemism antibodies were developed, but were not good for large epidemiological studies because were time-consuming, extremely expensive. And we start really to see the rampage of, the epidemiological studies when new tools like the human TTG antibodies became available in the late 90s. And, this really brought this, large spectrum of screening of celiac disease worldwide, starting from, North America and then in Africa and then in Asia and so on and so forth, that led us to conclude that celiac disease frequency is roughly 1% worldwide. Indeed, we passed from the old celiac disease epidemiology concept in which we thought there was extremely rare, only in kids with a wide fluctuation in space and time in terms of incidence. And again, in the late 70s, early 80s was roughly 1 in 300 in Europe, 1 in 10,000 in the United States. And because of that, we thought that this was really confined to Europe as a condition. And then minds of celiac disease have been found when these diagnostic tools were refined, again, among relatives, because this is genetic disorders, with patients with exintestinal symptoms, and then the comorbidities, and finally, the large, part of the healthy groups. And we doing studies on blood donor students, general population, realized how big is the magnitude of the problem. This is a landmark study that was published only 10 years ago, but believe it or not, is the one that really turned the tide of interest of celiac disease and other gluten-related disorders in the United States. Before this study, again, the concept was celiac disease spared this continent. And, this study for the first time showed that there was a prevalence close to 1%, much higher in subject at risk, 3-5%, depending if you talk about symptomatic subject, subject with symptoms related to celiac disease, or first or second degree relatives of people with celiac disease. Nevertheless, there is a gap, and it's also unique about celiac disease among all autoimmune diseases, between the people that have been diagnosed and the projected number. Now, this is a rather old slide, but it didn't change that much. The Swedish yellow line diagnosed is up here roughly to 40%. In the United States, it's up here roughly 10%, but we didn't move that much, despite that the awareness is pretty high now everywhere. So, how to close this gap? If we want to follow the World Health Organization criteria to screen all 340 million people in the United States, we have to satisfy all these criteria. Early detection on the basis of clinical presentation has to be difficult. And this criteria is satisfied in celiac disease. I told you this is a clinical chameleon. The disease must be a common disorder that cause significant morbidity in general population, otherwise it's not cost effective to do that. And we know that's the case. With 1% is one of the most frequent genetic disorder of humankind, and definitely, the morbidity is not trivial. You have to have a very effective screening tools, and I told you the anti-TTG antibodies is extremely robust. Of course, if you screen for something for which you don't have a treatment, it's not cost effective, but we know that the gluten-free diet is very effective in treating celiac disease. And finally, if not diagnosed, this can lead to consequences that can be extremely severe in terms of complication. We know that's the case for celiac disease. So we really have all the criteria, theoretically, to really support the concept of a mass screening of the general population. But this is not cost effective. The most cost-effective way, based on the studies that we and other colleagues have done, is actually to look specifically at the people that have the best return on investment going gluten-free, i.e. people that have signs and or symptoms that are being related to celiac disease. This is a study that was conducted in North America, now already 7 years old, in which we went to primary care physician, pediatrician, internist, and we said, if anybody comes in this clinic with any of these symptoms that you see here, bloating, chronic fatigue, IBS, constipation, so on and so forth, screen for celiac disease. And in doing that, these are the results. In this dashed line is the projected prevalence in the general population. Everything on the right is much more frequent, therefore worthwhile to actively do a case finding. So people with thyroid disease, with the families of celiac disease, with GI symptoms, iron deficiency, and chronic fatigue, the frequency is so high that it's cost effective to go for a screening. And matter of fact, when we talk about cost effective, for each individual that is being diagnosed with this approach, we have to spend roughly a little bit more than $6,000. What is the counterpart? What is the expense if we don't look at these patients and we let it go? Well, the estimate of the cost that is due to a long time, that is measured in years. Now, even if now we're so aware about celiac disease, the average interval between the onset of the symptoms and the time that somebody is diagnosed is 7 years, and the price tag of the 7 years of undiagnosed problem is close to $100,000. So it's definitely cost effective to go for case funding. And with this intervention, the capability to identify people with celiac disease in only 1 year in their intervention, this network of primary physicians was 40-fold higher. So for each individual was diagnosed with celiac disease before the intervention, 40 patients were diagnosed after the intervention. So where are we going from here? Where is the future diagnosis? Well, on the top of the list, particularly pushed by the pediatric population, is to find algorithms to avoid the intestinal biopsy that is considered the gold standard for definite diagnosis. I want to make clear that this is diagnosis for life. So we don't want circumstantial evidence. We want certainty. And so far, we were convinced the only certainty was given by the intestinal biopsy. Of course, the new frontiers is to find biomarkers that predict who are at risk for celiac disease is going to develop it to see if indeed we can eventually prevent celiac disease. And this is really focused on this interesting field of host-intestinal microbiome interaction. Now there is a lot of work on this. We don't have the time to talk about this during this talk, but eventually this can be a future of a subject of future discussion. And then, personalized medicine with pharmacoeconomics and so on and so forth. But of all this has been achieved already. So now there are a subgroup for kids for which the biopsy is not necessary anymore. We put out there a very provocative, paper in which we said maybe simple rules are better than complicated algorithms to diagnose celiac disease. And again, these rules were, revisited when we say, you know what, the 5 pillars that we want to make the diagnosis of celiac disease are absolutely present in the vast majority of people with celiac disease, but not all. So it is true that you have to have present signs and symptoms of celiac disease, positive serology, the compatible HLA, the intestinal biopsy showing the enteropathy, and the resolution of symptoms following implementation of gluten-free diet. It is true. And again, the vast majority of kids will fulfill this criteria. However, there are exceptions. For example, as I show you in the Celiac Iceberg, there are folks with celiac disease but no symptoms, asymptomatic. So they have celiac disease. There is a small percentage, roughly 10%, of false negative TTG antibodies. Still, they have celiac disease. I also told you it's extremely rare, almost impossible, but you can develop celiac disease without the HLA, 1%. Even intestinal biopsy, we consider gold standard. Sometimes we go in, and either because the lesion is patchy or it's too distal for the endoscope to reach, we found negative biopsy, but still these people, they have celiac disease. And sure enough, who is engaged in clinical activities is aware that sometimes, despite the good implementation of gluten-free diet for months and months, sometimes the symptoms do not resolve right away. All this to say that if we change slightly approach and say, you know what, rather than to satisfy all the 5 criteria, if we satisfy 4 of the 5 will be enough, we can make the diagnosis of celiac disease. And indeed, nowadays, also embraced by the new guidelines of the European Society for Pediatric Gastroenterology and Hepatology and Nutrition, if you have signs and symptoms of celiac disease, If you have a positive serology 10-fold higher than normal, if you have the HLA is compatible, you can skip the intestinal biopsy and put these kids right away on a gluten-free diet. And if the symptoms will go away on a gluten-free diet, the diagnosis is completed without the necessity to do the endoscopy. So these are the new rules for a subgroup of individuals affected by celiac disease. So to wrap it up and finish, what is the diagnostic approach that we have now based on guidelines that have been approved? If the individual has symptoms, like the typical symptoms or, short stature, delayed puberty, animal defects, anemia, and so on and so forth, history and physical exam and initial evaluation are important. The screening test is a must. If it's abnormal, needs to go to the pediatric gastroenterologist. And from there, an endoscopy needs to be done. And if the histopathology of celiac disease is there, the diagnosis is confirmed and the kids go on a gluten-free diet. If the TTG is not abnormal, celiac disease is not impossible, as I told you, it's unlikely, and needs to be evaluated further. And if the histopathology is negative, you need to review the histopathology, consider the HLA, and repeat the biopsy, because chance exists that you missed the place where the damage was. In the asymptomatic patients, the algorithm was slightly different. We're talking about first-degree relatives, they're screened, comorbidities with diabetes, autoimmune thyroiditis, and so on and so forth. So the clinical suspicions because of the comorbidity, the TTG, if it's abnormal before to go to the endoscopy, and because they are false positive for people that have type 1 diabetes and Hashimoto thyroiditis, the anti-endomysium antibodies is much more specific, needs to be done, and if it's positive, then goes to the gastroenterologist for the endoscopy and the diagnosis and so on and so forth. If the TTG is not abnormal, the HLA should be considered. And finally, these are the new classification that's been proposed for gluten-related disorder based on pathogenesis. Autoimmune, the ugly celiac disease with this permutation of gluten ataxia and dermatitis piriformis and the different subgroups, symptomatic, eyesight, and the potential. Allergic with allergy with all the repertoire that I showed you when we discussed the matter, and then non-autoimmune, non-allergic, most likely driven by innate immunity, gluten sensitivity, with the understanding, again, we have biomarkers for celiac disease, we have biomarker for with allergy. We do not have biomarkers yet on gluten sensitivity, we're working on it. And finally, this is a table with some guidelines, how to make the differential diagnosis among, the ugly, the bad, and the good. So time interval between gluten exposure and onset of symptoms goes weeks, and sometimes here for celiac disease, minutes for with allergy, in between hours to days of gluten sensitivity. The pathogenesis, I told you, autoimmunity for celiac disease, allergic for with allergy, we don't know yet, but most likely innate immunity for gluten sensitivity. The HLA is totally restricted for celiac disease, as I told you. For wheat allergies, like the general population, for wheat sensitivity is half away. It's 50% yes, 50% not. The autoantibodies, by definition, are almost always present in celiac disease. By definition, it's a criteria to rule out, it has to be negative in these other two conditions. Same for the enteropathy, that's almost present here, always absent here. The symptoms completely overlap, so you can make the differential diagnosis based on a clinical presentation. And the complication, for whatever we understand right now, there are comorbidities I discussed with you about celiac disease, while there are no comorbidities for these other two conditions. So in this 55 minutes, we reviewed of roughly 50 years of history of what we understand about the gluten-related disorders with some guidelines. Really, I hope that you appreciate that, this is a work in progress. So it's something that, again, will have an evolving of the knowledge that we have in terms of gluten.